And right about now, we are due for the Western Spectrum, and today we are talking about the sickle cell. What is the sickle cell trait? What is the sickle cell disease? And this is a condition that is we're told it is quite rampant in the Western part of Kenya. We want to know why. We are here with a team that has all the information that we need to know about the sickle cell. And September, being the Sickle Cell Awareness Month, this conversation is very vital. And this morning, thanks for joining us. My name is Wycliffe Okech, and with me here is a very able team, actually, that has all the information, like I've said, regarding sickle cell. Starting closer to me is Michelle Omulo, that is a sickle cell warrior. And just right in the middle, that is Dr. Ochieng Masawa. He is a consultant clinical pathologist, and to the extreme end is the acting chief executive officer in charge of the Jaramogi Oginga Odinga Teaching and Referral Hospital. Thank you so much, ladies and gentlemen, for making time for us this morning. The sickle cell, Daktari, I will begin with you so that we may be able to be at level with our viewers right about now. When we talk about sickle cell, what should hit our mind? What is this sickle cell that we talk about?
Okay, good morning, viewers, and thank you, Wycliffe, for this opportunity. And when you talk about sickle cell as a disease, this is a chronic, non-communicable disease, just like we talk about hypertension, cancer, non-communicable diseases. This is a chronic disease that affects a protein molecule of our red cells, and in particular the hemoglobin, which is charged with the responsibility of carrying the oxygen in the red cells. And red cells are among those cells in our body that do the function of transfer of oxygen or transmission of oxygen within the body. So when these red cells, hemoglobin, is affected with this genetic disease or a hereditary condition due to mutations that take place in the formation of this hemoglobin, it results to an abnormal hemoglobin called hemoglobin S, which does not function as expected. And that means that these abnormal red cells results to the development of this disease called sickle cell disease.
All right. You have on the patient, or rather, who is carrying the trait?
So being a genetic disorder, we normally say recessive inheritance. That means that it takes two couples, a couple, one being a carrier and another one also a carrier, to develop, to give birth to a child with sickle cell disease. Otherwise, other children can only also be carriers. So it means that a carrier will present normally and does not experience any problem here and there, mild anemias, but they behave in a normal way. Okay. But those who have inherited the dominant disease, that is the homologous SS in their hemoglobin, they present with frequent anemias because this abnormal red cell tends to sickle. Sickle is a curved nature of that red cell, and it means that it is not flexible enough as a red cell to go through the vessels. And that makes it fragile and breaks easily, and also sticky, that it blocks the vessels, the narrow vessels through which blood is supposed to flow, causing the blood to be thick, and thus the increased viscosity of blood causes occlusion, and through this the pains develop. Yes.
Wow. The person with this condition will experience constant pain.
Definitely, yes. We have frequent pains caused by a common crisis of pain and vasocclusion. That means the vessels are blocked so easily due to poor flow of blood. to the different organs that is expected. So they experience pain, that is a frequent thing, and anemia because of hemolysis breakdown, premature breakdown of red cells. Normally a red cell takes 120 days before it is naturally dies or destroyed. But the red cell that is affected with hemoglobin S will take between 16 and 20 days. Yes, and that means that premature destruction will take place, and anemia and frequent pains will be the resultant.
Just hold it right there, because you talk to us about the statistics and why this condition is quite rampant in the western part of Kenya. Michelle, I want to rope you in. Tell us, when did you realize you have... how has been the experience? How has been the experience?
Okay, I realized that I had sickle cell at the age of 3 when my mom took me to Kenyatta National Hospital to get tested because she saw my eyes getting jaundiced. That means yellow. So that was quite strange for her. So she had to take me to the hospital so that they can get tested. So when I was confirmed that I had sickle cell disease, it was not strange to her because it was in the family. My dad's sister, the last born sister, had sickle cell disease. So it was not something that was new to her. So she just started on the management techniques and ways right away. Yes.
Dr. says, or rather brings about immense pain to the carrier of the deformed red blood cells.
Yes.
Did that actually manifest in you?
Not really. Not really at that time when I was being diagnosed, but along the way it manifested. Yeah, it manifested. I had painful crises. I was being admitted here now and then, every occasionally, like not even occasionally, but frequently. Yes.
Okay. And the response towards this?
The response towards this was.
How did your parents?
I grew up with my mom. I grew up with my mom because my dad died when I was 10 months old.
Sorry.
It's okay. So I'm the last born in a family of 4. So I have 3 older siblings, 2 sisters, and 1 brother. So
among your siblings, you're the only carrier?
I'm the only sickle cell warrior. I'm the only affected one. The rest are carriers.
All right.
Carriers of the sickle cell gene.
Carriers and someone who is a carrier and someone who has confirmed to be positive of this disease, what is the difference?
Yes, so you can see. Yes, so you can see that in Michelle's family, that is 25% affection that took place. That means out of 4, she's the one bearing the disease. A good proportion of distribution, like what normally happens. So the carrier has hemoglobin AS. Yeah, the diseased person or the affected person has hemoglobin SS. That's a homologous state of that is expected to develop a disease. So the carrier can only later on, if they get married, for example, to somebody who is a carrier, that's when they can end up with an offspring who is a dominant, again SS. Otherwise, they will be normal. They'll just grow up normally. They can donate blood to any person, and occasionally they can develop mild anemias, but they're normally.
Okay.
Yeah. So the only one who is affected. And remember, Michelle has said that the first thing that the mother discovered was yellowness in the eyes. Yeah. Frequently, that is the common, sometimes the only symptom or sign that you will see. The yellowness is a result of the same breakage of red blood cells giving out the component that is in with the red cells, that yellow coloring effect into the system, into the blood, and that will manifest in the eyes as yellowness. So sometimes when you see yellowness, that probably will just mean that hemolysis is taking place and that child should be taken to hospital.
The yellowness of the eye?
Yellowness of the eye.
What else?
Yeah. Of the eyes.
What else?
Yeah, those pains that we talked about, joint pains or major joint pains, or a child who is frequently developing anemia. Yes, okay. Despite mild illnesses.
So that we can bring, before bringing the CEO to tell us about the investigative strategies, tell us about the statistics. Why this condition is quite rampant in the western part of Kenya?
Okay, thank you. Okay, thank you. The thing about statistics is that, now we are talking in Kenya, it's more frequent in the western region, that is within the lake belt. But this disease affects, globally, you will find that the projections are up to 25 million people are affected in the world. But within this 25 million, up to 15 million are in Africa, the Southeast Asia, India, and those regions, yeah, the Mediterranean region. But when you come to Africa again, the sub-Saharan region is very much affected, yeah, with the disease. Up to 250,000 people are affected. Now, when you narrow down to our country, again, we see this in the western side of the Great Lakes countries, that is even Uganda, Tanzania, those areas that are around the lake. And the unique thing about this is that this belt is favorable for the breeding of the Anopheles mosquito that transmits malaria. Sure. And due to natural selection, natural occurrence, because of the existence of malaria, you find that the mutant gene that causes sickle cell leads to the development of a trait. Yeah. So naturally, people within this belt developed traits because the trait AS hemoglobin offers resistance to malaria. So that's just naturally occurring. So that is where now sickle cell comes in, because some people develop AS in their system as a means to fight the disease malaria. And in the long run, now when they meet and marry each other, they result with a homologous SS resulting to malaria. So you'll find that in our country right now, in the western region, or let me say Kisumu, we are talking about 4.5% prevalence. And from what we are doing in Jaramogi in terms of newborn screening, we have screened about just slightly more than 32,000 children or neonates, and we are having now 2 to 3% prevalence from that study, and about 18% are turning out to be trait. Yeah.
Jaramogi Hospital is the biggest health facility in the region that receives referrals from the other hospitals down, ranging from level 1 all the way to level 5. Dr. has mentioned that there is a prevalence of about 4.5. About 4.5 of the total population living on the lake belt, that is Kisumu included, is carrying this disease. What are the mitigative strategies?
Thank you, Wycliffe. I want to mention that at the facility, and not at the facility alone, and even within Kisumu County, we have come up with various strategies. Sure. And this started way back in 2021 when we started now proper screening and to get the population of these people that are having sickle cell disease. And then thereafter, Kisumu County, together with the management of Jaramogi, came up with a slogan of zero sickle cell disease within the western region. And that has been a great milestone. And so in Jaramogi, there's this drug that these patients are using called hydroxyurea. We have tried our level best to ensure that that drug is always available in the facility, because if they don't get it, they go through a lot of pain. And something that I want to mention, that quite a number of the population that we are seeing in Jaramogi, there are people that actually cannot afford out of pocket.
Oh, yes.
Meaning that they cannot go to private facilities where they can get drugs available in the stock.
All right.
And we took cognizance of that particular fact, and we say that being that this is a burden in the Western region, what can we do as a facility to ensure that when these people come, they actually get drugs? So through the budget, we ensure that we properly budget for the drugs.
Okay.
For the sicklers, so that when they come to the facility, they don't experience stockouts.
Okay.
And I think for the last 1 year, 1.5 years, Michelle, I can confirm that we have enough drugs that are used to contain pain and manage pain within the facility. Something else that we have done before this facility was actually elevated to a level 6 national parastatal. It was still under Kisumu County. And through the governor, we decided, and the board of management of Jaramogi, we decided that being that this disease is a burden in our region, why don't we just designate a facility to manage this particular disease? And that's why we renovated the Victoria Annex, where we are today, to be a sickle cell center, a center of excellence for sickle cell management and hematology. So we transferred all our clinics, adult clinics and children clinics, to this particular place. And not only that, we also have a plan that what else, apart from giving these people drugs, what else, how can we actually reduce the spread of this disease within our region? And that comes for awareness. We are working closely with the CHPs to ensure that we create awareness within the society and the communities in Kisumu County, and not only Kisumu County, it's affecting the Lake region. So we are creating awareness through the radio talk shows, through TVs, and through the level 1, level 2s, and level 3s, so that they can get early screening, and the treatment can begin. Another thing that we have done is we have allocated some money to put this place a proper hematology. And I think in the near future, we are even thinking of conducting bone marrow transplants. Those are the services that you cannot get them in any public facility in Kenya. But being that this region, we are experiencing that particular burden, we decided that we want to make a proper center here for sickle cell treatment. So if I can mention, in the 25-26 budget, we have allocated 100 million for a start by the national government, being that we are now under national government, and I want to appreciate the Ministry of Health for that.
We'll come to that, yes.
Thank you. Yeah.
Who is awareness creation?
Yes.
And just about the elevation of the Jaramogi Oginga Odinga Teaching and Referral Hospital to the level of a state parastatal, I think it happened not more than 5 months ago, right? Yes. And by then, the facility was under the county government, and there could be an allocation of about 2 billion annually towards Jaramogi. And now that it is a state parastatal, how do you expect that to change the scope of operations of the facility with regards to mitigating sickle cell condition?
I think the 2 billion that you have talked about was including personal emolument. So basically, you will find out that what goes to the current operation is very little. And that's why most of the times you could experience stock out. Because Jaramogi is not only serving Kisumu, we are serving 19 counties and other 3 countries bordering, that's Uganda, Tanzania, Eritrea, and South Sudan, and quite a number of them, around 4, and plus 19 counties. So Jaramogi had grown, and I think the county could not contain it anymore. So the good thing is that the money that the national government is now taking over from Kisumu County's budget, Kisumu County can now use that money to actually ensure that the level 2s, they equip the level 2s, they ensure that they provide necessary requirements for sickle cell screening, and also employ more staff that can intervene in terms of screening and screening for these services so that we get intervention early enough. So that's what the Kisumu County is going to benefit from Jaramogi now being elevated, because it's taking around 1.2 billion out of their budget.
Yes.
So that money they can now use to budget for medical drugs, employ more staff to ensure that we get early diagnosis and the treatment begins early.
Okay.
Yeah.
Yeah. Now we are talking about screening. We have talked about awareness creation, but then there's also a mitigative strategy, that is the red blood cell. Briefly about that. And Dr. when we talk about screening, is the screening just for the newborns, or even the adults are also being screened for sickle cell?
Yes. Yes. It's not basically for the newborns, because what currently is running is for the newborns in our facility. But we would want to see that in our young adults, the screening to be done, like if we were to have resources, we would carry out this process even in our schools, target the high schools, because these are the young people who tomorrow are going to have their families, and we don't want them to be agents of creation of more sickle cell disease cases. So the screening process is something that, together with awareness creation, that needs to be done, especially targeting the young adults and that infant stage, so that brings in the best way to prevent or to control sickle cell disease.
Okay.
If one knows that I am a trait, then now they know that next time if I'm to hunt for a girlfriend to get married, then I should probably move a little bit out of Kisumu to another county, for example. Yes, or if I manage to convince my girlfriend to also undergo through the screening, then I'm very sure that I am a trait. He or she is an AA, hemoglobin AA, and no chances of bringing to this world sickle cell disease.
So that must it be a policy that before marriage, the couples, the lovebirds must need to test for sickle cell? Should we have a policy like that?
Having a policy like that is not easy, because love is in the eye of the beholder, they say. And if somebody has developed genuine love for Michelle here, there is no reason why you should compel. In other countries, for example, there are such strict policies that genetic counseling is mandatory, and genetic testing, preconceptual testing is mandatory, and you cannot just marry somebody based on love and you are going to give birth to sickle cell disease cases, because this is a burden not just to the families but to the government.
Sure.
Yeah.
The resources that the hospital uses to manage these cases are immense resources. Thank God SHA is now coming in to help us offset this. But the financial implications of managing sickle cell is enormous to the family and to the government, because it requires resources. So a good government can go to that extreme of having policies, especially the much prevalent areas like in the Western Belt, that young people or young couple should actually test themselves, because again it's affecting those families by separating. We have seen in Jaramogi where we have tested newborns, and once the parent is told that the child is affected, the next time you see this couple, it's a mother alone coming with the child.
The dad is...
Yeah, the dad has taken off. Yeah, because of the wrong belief that it is the woman who brought this.
Isn't that stigma?
It's a lot of stigma, definitely, Cliff. It's a lot of stigma to those families, and unfortunately, the women suffer more. The mothers suffer more because they are left with these babies, and men take off most of the time thinking that this is something that has brought about by this lady. Yeah, but it is because of lack of awareness.
All right. Lack of awareness. The CEO mentioned that this awareness creation is something that the Jaramogi Hospital is going to focus on quite massively now that it is a state parastatal, and it has the resources meant for that. We've spoken about screening, which is quite vital for the newborns and also for couples. We've spoken about awareness creation. Banasio, talk to us about the red blood cell exchange program that was launched here just, I think, last week. Yeah. Yes.
So thank you. Thank you. I think that's one of the strategies that we have put in place to just like a stopgap measure among the plans that we have in future. As I've told you, Wycliffe, we have great plans, and even before this facility was elevated, we already had some development partners that were actually willing to come and partner with Kisumu County as far as development of hematology center here is concerned, because this is a great concern to the governor of Kisumu County as well. So the plans are still underway, and even what the national government has put in is just also to support. This red blood cell exchange that we initiated last week, and it will go on. We enter into agreement. We call it MOC, Memorandum of Collaboration, under public-private partnership to ensure that we support these our people. I mentioned to you that some of them are not able to go to Nairobi West because of lack of finances and resources. But if we can now bring this service home on the ground in a public facility where they can just walk in, use SHA, and they get treatment without any top-up, that's something great, and I really want to appreciate Nairobi West for collaborating with us. So it's a program that is going to continue, and I'm happy that our patient 001, Michelle, is here, and you heard from her that she's now feeling okay. She's feeling like there's a burden that has gone away, the pain and the fatigue. That's something, that's great. And when Michelle visited my office before the exchange, I talked to Michelle, and Michelle told me, the pain that I'm going through. We are living under uncertainty. We warriors. We don't know what may happen tomorrow. And that thing really got into me. Like I came to think about it, and I told my team, we are not going to wait any longer. We must have this thing started and up and running. So that's why we now started the conversation, and within 1 week, the place had been set, and we had Michelle going through the red blood exchange. So it is something that's very good weekly, and it's something that I think we, as a facility, we are very happy and are going to continue with it.
Before we come back to you on the sustainability of this program, Dr. Harry, red blood cell exchange, in brief terms, what is it?
As the name says, it's the exchange of red blood cells, a therapeutic method of managing anemia of sickle cell disease, because most of the time we manage them, remember, because they are presenting frequently with anemia and low hemoglobin levels. They tend to suffer or to undergo frequent transfusion procedures, and the simple transfusions are really not helping the sickle cell disease warriors, because it comes with its own challenges. Because it leads to iron overload, because we frequently give them red cells, and these red cells carry iron in them, and we keep loading them with a lot of iron. We eventually sometimes worsen their situation through simple transfusions, because a normal sickle cell disease patient should not have hemoglobin running above 10 grams per deciliter. So you want it to be maintained within 10 or around there. So most of the time, our clinicians do simple transfusions or top-up transfusions with red blood cells. But we are looking at a situation where in red blood cell exchange, through an automated process, and this also means that you can do it through manual, though the automated way is the best.
All right.
It's a therapeutic process where the red blood cells that are affected by or that are sickled in the patient, they are removed, and at the same time, they are given fresh, normal red blood cells in a continuous flow. Yeah, so actively, the patient is in a donation bed or in a normal bed, and there is access, venous access, that is done in such a way that his or her blood is removed, and at the same time is being given fresh, normal, donated, cross-matched blood according to their blood group at the same time. So this blood is going through a machine, and this machine, using the principle of continuous centrifugation, separates the sickle cells into a separate bag, and normal blood cells is transfused to the patient at the same time.
Now, this is clean blood with no sickle cell.
This is clean blood from a normal person, donor, with hemoglobin AA, who has donated. And I must say, even traits can donate blood for transfusion. But if one is known to be a trait, we don't recommend that they should be the one giving the blood to a sickler, because they also carry some percentage of hemoglobin S, which can build up on the patient one.
Okay.
Yes.
Patient. You are the first person to undergo this procedure.
Yes.
Right here at the Jaramogi Oginga Odinga Teaching and Referral Hospital, Victoria Annex, where this is a dedicated facility for patients like you. You earlier mentioned that before the procedure, you used to experience constant fatigue, and now you feel relieved.
Yeah, I feel relieved.
That particular process, how do you remember anything about it?
Yeah, I remember very many things about it. When I last week on Tuesday, actually, we were taken through a series of, documentations, and there were trainings actually for the red cell exchange. Nairobi West was there, and they were training us on what to expect and what not to expect.
Okay.
So I really had, when I came here on Monday, I really had it like...
You didn't feel the scare?
I was scared actually, because I was all alone until my mom was called and came, and then I said, okay, let me just go ahead with this, because I'm the only one who is going through this procedure, and it would be quite unfair when people have called media stations to come and witness, and there would be no one to be taken, to be filmed. So I was like, okay, let's just go through with it, and Mungu mbele.
How long was it?
For me, I think it took...
How long was it?
About 2 hours, 2 hours, 30 minutes.
Okay.
We were done with the process.
Okay.
And allow me, sorry to cut you short, to congratulate Michelle, actually, for coming forward and accepting. This is a fast procedure, and and just like any medical intervention, you will feel scared.
Sure.
And the number of blood packets that we are going to pump into you can scare you. Yes, and it can also come with its fair share of complications, so to say.
Is the patient put on is it anesthesia?
Put on something to numb the pain. Put on something to numb the pain for a bit, because I was taken to the theater to be put on the catheter. Yes.
Right.
Yeah.
So, feel anything?
I couldn't feel anything.
Until it was over?
Until it was over, I couldn't feel anything. It was over, I couldn't feel
anything. And probably just immediately after the procedure, did you feel what you felt before the procedure?
Okay.
Before the procedure?
Okay, during the procedure, I felt really cold because of the cold bloods, the cold red blood cells being added to me. So afterwards, I never felt anything and had no complications at all. Yeah, everything was just okay. Yeah, the process was very smooth.
Is the patient put on a monitoring bed for how long? Bed for how long?
Okay, just like we do the normal blood transfusion, you need to monitor the patient so that there's something called transfusion reactions. And these blood transfusion reactions, they can happen anytime because we have the acute ones and we have delayed ones. So we observe. The observation starts right away, and that's why I think this whole process is courtesy of a multidisciplinary team. Sure. You find that we had not just the support of the administration present to avail anything that we would require in case of emergency, the anesthesiology team, the pediatric team, the physician, and the nursing team, apart from the technical team that ensures the blood is flowing normally. So you start monitoring from the beginning in case of transfusion reactions, and just within 30 minutes or so.
Percent prevalence in Kisumu. Banasio, tell us about, because this is patient 001. We know that after this success story, many patients will flock in. Tell us about the sustainability. Will Victoria Annex accommodate all these patients?
Actually, weekly we are receiving quite a number of calls, and quite a number of patients are walking in asking for this particular procedure. But I want to inform the public that we are prepared. We had plans even before we started the first one, and we have put everything in place. So I'll speak to that in I think 3 areas. Number 1 is on the issue of the training.
Sure.
Number 2 is on the issue of the medical equipment. And number 3 is on the issue of the financial sustainability. And maybe the 4th one on the issue of community engagement.
And also don't forget about that.
So on the issue of the community engagement, one of our pillar in our strategy is to engage with the community. And that one will assist in terms of sustainability, in terms of screening and creating awareness. Sure. And already we have allocated some funds for medical camps within the peripheries and working with the level 1 facilities, level 2 facilities. And going forward, we lift the mechanism that we have put in place, not only for the sicklers, but also for other diseases. We are going to send our consultants on the ground to run medical camp, and complicated cases will be referred to the hospital so that we manage them early enough. So that one I can say without fear of any doubt that we have allocated some money for that particular community engagement, creation awareness, and also providing the non-pharmaceutical and everything that would be required to do that. On the issue of medical equipment, yes, we have started under public-private partnership, but we are also looking for, there's a program called NESP. If we can get these equipment, additional ones under placement through the NESP program, that's National Equipment Service Program. If we can have those, maybe add 3 or 4 on top of what Nairobi West has provided, because the number, as we has estimated, it's going to be quite overwhelming.
How many machines do we have right here?
Currently, we have 1.
Just 1?
We have just 1, but Nairobi West promise they are going to provide the second one.
All right.
But again, we have started the conversation if you can have the 3rd and the 4th one, even the 5th one through the NEST program.
Wow.
Because that's a government initiative. And when they come, actually, they just use SHA to pay for the services.
Right.
So the good thing that...
But yes, that is very critical. It's only SHA that is, they use, exclusively use SHA.
Yeah, in a public facility, actually, it is SHA. And, I won't tell Wakina Michelle to top up because I know
Yeah.
I know some of us come from the background, financial difficulties, and then you tell them you come for this procedure, and then you have to top up. Then you're just sending most of them to go die slowly at home. That one, as a facility, we and working very closely with the government, even if there are other costs that will be involved, we'll see how the government will come in to provide money to cushion those other costs. So that one I can promise the public and through the Ministry of Health that will ensure that when they come, they use SHA and in a public facility. On the issue of financial sustainability, I'll say that we have allocated some money in our budget, and we want to appreciate the national government for accommodating that in the budget of 2025-2026.
Oh, yes.
I know we have started in a small way, but a journey of several thousand miles start with one step. I know we'll get there at the end of the day. So we have allocated around 100 million just to establish a sickle cell, a center of excellence for sickle cell anti-hematology, right here where we are today. Okay. And going forward, we are also going to welcome other partners that are interested, the well-wishers, that are interested to help this initiative. So we welcome.
All right.
On the issue of blood, this process requires a lot of blood, weekly. A lot.
Yes.
A lot. And we want to appeal to the public.
Oh, yes.
Please come, donate blood.
Yes.
Yeah.
Make that very clear, because we are now running out of time. Clear.
I want to appeal to the public.
Yes.
This process of red blood exchange requires a lot of blood. We have already established blood transfusion units in Jaramogi Odinga Teaching and Referral Hospital, and we are working very hard to ensure that unit runs 24/7. So please walk to the hospital, donate blood, and save the lives of many Kenyans that may need this particular procedure. You can also go to regional blood transfusion center just next to Jaramogi Odinga Teaching and Referral Hospital and also donate blood. So we request all of you, please come to the hospital and donate blood so that we are able to continue with this process.
Dr. just one in less than a minute. Michelle, I'll also require to say something just in less than a minute in our closing remarks, because we are now pressed on time. Going forward, Dr. what would you want to be added to this whole strategy of mitigating and having zero sickle cell?
Yes. Just before that, the quick thing I would want to say that this is a day case procedure. Sure. This is a case that this is a procedure you come, you undergo it, and you go home. So it doesn't require admission.
Sure.
So however the facility may look, it can accommodate so many people once we have the machines.
All right.
The other thing is that it requires the participation of all of us. It requires the support from the public by heeding to the appeal, donating blood, and also registering for SHA. Once people register for SHA, and the affected patients are so many, they will come, they undergo this noble and deserving procedures, and they will be well, because we are interested in them having their normal lifestyle and carrying on with their duties,
Michelle,
with their works.
Apart from being a sickle cell warrior, I understand you are a chef, you are a filmmaker. In just less than a minute, totally, maybe in 30 seconds, tell us, what do you want to see the administration or rather the community doing about awareness creation in less than a minute, please?
I would want them to create awareness in a way that it makes sense to the communities, because we are from the communities. So we are championing for a good cause, and we would not want this to really, be taken lightly.
All right.
So I would really want us to create awareness in communities, also get funds to do the awareness creation.
All right.
Yes.
Thank you so much, Michelle. Yes. For early diagnosis, early detection, it's about awareness creation, and it is about the availability of blood so that this procedure can be sustainably managed here at the Jaramogi Odinga Teaching and Referral Hospital, Victoria Annex. And that is where we put a cap on our conversation this morning. I wish we could have more time, but then again, we'll continue this conversation another day. And many thanks to you, gentlemen, especially CEO Joshua Kise, for creating this time for us to have this conversation, and also the entire team from the Jaramogi Oginga Teaching and Referral Hospital for the good work they are doing here too, so that we can have zero sickle cell cases, but again, for those that have been confirmed to be positive, and also carriers, so that this condition can be well managed. Asante sana Daktari, you've given us the critical nitty-gritties that we needed to know about sickle cell, and also patient 001. Thank you for coming forth to talk to us about this whole experience. Right about now, that is where we put a cap on our conversation this morning. Thank you for tuning in on Western Spectrum segment on the Good Morning Kenya show. My name is Wycliffe Okech, and also allow me to extend our appreciation to the entire production team led by my able producer, that is Johnny Mohika back in Nairobi, and of course my our guys behind the lenses, Simon Nyamatiko and Martin Kivuti behind the lenses, that are beaming this conversation live on air. That is where I put a cap, and my name is Wycliffe Okech. I'm now handing you back to the broadcasting house in Nairobi